Hello and welcome to today's webinar put on by the British Lymphology Society. Today we're going to be talking about lymphedema and is it a risk after pelvic cancer treatment? Just to introduce myself, my name is Matthew Griffiths. I work in the National Lymphoedema Service based within Wales, and I've been supporting lymphedema patients since about 2019. Currently, I work mainly with children and young people who have lymphedema, but I also support various programs of work within Wales, such as the Surgical Lymphedema Programme, Cellulitis Improvement Programme, and our national complex clinics as well. Um, I'd like to just take the opportunity to thank the BLS just for working so hard to make these sessions available for us. I've been enjoying, and I also look forward to the other speakers' topics as well. So. The aim of today's session then, so it's to understand the risks of lymphedema post-pelvic cancer treatment, and recognize the prevalence of pelvic cancer-related lymphedema, understand the impact on quality of life from lymphedema following pelvic cancers and its treatments, and also understand the importance of early recognition and explore prevention and management strategies. So, what is lymphedema? I'm going to go over this quite quickly because I'm hoping many of you will already know. I've included a few definitions of lymphedema here for you, but the important takeaways for me are one of the three main functions of the lymphatic system is tissue fluid homeostasis. Lymphedema is swelling due to a buildup of lymph fluid in the tissues, normally as a result of inadequate drainage. And there are many different causes of lymphedema. It can be split between primary and secondary. So primary being due to a genetic fault, secondary being something that's caused the lymphatic system to not function as it did. And some of the common secondary causes we can be considering are obesity, lack of movement, cellulitis, wounds, surgery, disease itself, and many more. So just understanding the pelvic area then, which I feel is quite important for this topic. So the pelvic area involves all of the structures depicted. So we're talking about our sex organs, bladder, section of the small bowel, lower end of the large bowel, so the colon, rectum, and anus, um, along with bones, lymph nodes, blood vessels, nerves, so on. So it's quite a vast area, hence the overview today and a bit of a disclaimer. I'm not going to be able to go into too much detail within the time frame. Um, there are a few areas here which are within the top 20 cancer incidences, which that affects. Um, and in terms of lymphatic drainage routes, then for males and females, there are some slight differences, but a quick and easy way to remember this is everything external, so skin-wise drains to the inguinal nodes, and everything internal drains to the lumbar trunks. And just taking us to understanding some of the different treatments then, so we could be talking about surgery and radiation affecting these areas. So incidence of the most common urological cancers for males and females combined then. So to help us understand the impact, it's useful to understand the incidence for disease in these specific areas. As you can see when looking at urological cancers, and we'll continue to see with others as well, is the incidence between different diseases can vary quite a bit, as does the incidence of lymphedema in these different cohorts as well. What I found quite interesting here, though, just having a look at this, was males present with quite a higher incidence than females when we're looking at urological cancers specifically. Here we can see prostate counting for quite a significant number of all cancers, taking up 14% overall. And if just narrowing down to males, about 27% of that cohort. Approximately 1 in 10 people treated for prostate cancer experience lymphedema, and almost 1 in 1 people treated for penis cancer have lymphedema afterwards as well. Okay, so moving on to incidence of gynecological cancers in females. So cervical and ovarian cancers are in the top 20 most common cancers for females overall, ovarian being the sixth most common. A study looking at factors influencing lower limb lymphedema after cervical cancer treatment revealed an incidence of an increased risk, sorry, of lymphedema with patients with vaginal diseases, heart disease, abnormal menstruation before cervical cancer diagnosis, and we're talking about approximately 36% of this cohort have lymphedema. Um, Just looking at the incidence of gastroenterology cancers in males and females combined as well. So here we can see that bowel cancers take up another significant figure of cancer patients, 11% of all cancers combined. So lymphedema prevalence then, so lymphedema risk varies on different types of cancers, when alongside other known conditions as well, and also the different types of treatments. We know that generally the more extensive and radical the treatment usually means the higher risk of lymphedema. We also need to remember that at least 1 in 10 people with bilateral leg edema have genital edema too. So I think as healthcare professionals, it's important for us to just be aware that one of the biggest barriers for us identifying this is healthcare professionals ourselves not asking. So to help us, we can consider things like self-report tools for patients. I also feel it's important to note here as well that we should be considering recurrence or new disease with new unexplained swelling. It's always important to understand our patient's history and assess holistically. So, understanding the impact on quality of life. So, why is this important? Well, I think it just goes alongside our move towards a biopsychosocial model of care, sort of evolving from the basic medical model of care. So, physical side of things, we're thinking about pain, heaviness, walking, personal care. Emotional side of things, we're talking about body image and anxiety. And then the social side of things, we're talking about things like shopping, home life, hobbies, work, finances. You can see shopping being one of the highest scores for first digital proms within Wales. Um, in Wales, we use a validated tool called Lymprom. Just on the topic of proms and so patient-reported outcome measures, I found it really useful in personal practice, and it really does help me prioritize and focus on individual appointments to ensure I'm addressing what's truly having an impact on patients. And I think it's also important that we consider, especially when talking about biopsychosocial impact in a wider context, that the patients that we're talking about now are cancer survivors too. So just an example is a study suggested that cancer survivors with lower limb lymphedema report a higher prevalence of fecal incontinence. So, so just sort of considering that there's layers of impact within what we're talking about, not just the impact of lymphedema. What can we do then? So, risk reduction. So many different risk reduction strategies, including increasing knowledge and awareness with our excellent oncology colleagues. We could be thinking about group sessions for patients, educating about the risks of lymphedema and how to identify and where to be referred. Think about what kind of timing would be best along that journey for them as well. Just being aware of everything that they're already going through and the information that they're already receiving. Um, and just reducing our barriers to services as well. So consider how patients can access our services and trying to break down some of those potential barriers. Can we be thinking about things like self-referrals, just to make sure people are able to get the help when they need it. And collaborative working as well. So, consider involving the wider MDT. We could be involving pelvic floor physiotherapists, particularly if lymphedema is internal. And when we're talking about treatment, we're talking about things like skincare to reduce risks of infection, movement and activity to promote lymphatic flow, compression garments to reduce volumes and control edema, alongside all the other things that we do as lymphedema specialists. But I think it's also important for us to remember that surgical techniques are forever improving. Um, There are lymphatic venous anastomosis surgeries now, LVA surgeries, lymph node transfer, scar release, liposuction, BioBridge, and so on. So just considering what options are available for patients as well. So just to conclude then, so lymphedema is a life-changing risk following pelvic cancer treatment. And early recognition and management is critical to improving outcomes for patients. Collaborative working and reducing barriers to accessing services will help us keep improving. And just to remember, I think we've all got the common goal of improving for our patients. We've got a wide, varied skill set between us all. I think it's just important for us to keep that safe space really where we can keep collaborating and working together for these patients. I think we're going to do a bit of a Q&A session now, so I'm looking forward to discussing with you guys. And yeah, thank you for listening.
Thank you very much, Matthew, and welcome everyone to today's webinar, day 3 of Lymphedema Awareness Week. I'm just so pleased that we're having this focus on pelvic lymphedema. It's such a big problem for our patients and something that, as a lymphedema clinician myself, I do find very challenging to treat, such a challenging area to get the compression right. So I'm really pleased that the BLS are having this sort of focus on the pelvic area. I'd just like to take the opportunity to thank Matthew and introduce Lisa. Lisa's joining us today from the Pelvic Radiation Disease Association, which is a charity supporting people with the late effects of radiotherapy. Just going to let Lisa introduce herself and tell us a little bit about the charity that she represents today.
That's great, and good afternoon, everybody, and thank you, Matthew, for an amazing presentation. So, as Lorraine said, I'm here representing the Pelvic Radiation Disease Association, of which I'm a director and trustee. But my background is very much in pelvic radiotherapy. I was a consultant radiographer in gynae-oncology, and very quickly became aware of the consequences and the implications of potential long-term effects of treatment. So I've worked closely with some of the leading surgeons and clinicians within the UK, looking at how we can develop services to improve patients' outcomes. I have since moved into my new role as centre head at Maggie's in Cambridge. And so Maggie's and Pelvic Radiation Disease Association have very much collaborated because not only from PRADA are we trying to look at education of patients and healthcare professionals, but also the psychological impact that late effects, of which clearly lymphedema is one of them, is what is that impact and how can we support patients with that psychological impact. So as I've alluded to, we very much focus on education, both of patients and healthcare professionals, and this led us to develop the best practice guidance on managing late effects of radiotherapy. So that's all inclusive. It's the lymphedema, it's menopause, it's the urology impacts, nerve damage. And what it's doing is just highlighting the challenges that all of those can come together. In my role as centre head and supporting patients with complex challenges, it never ceases to amaze me that we get people that come through who say, well, I'm seeing a urology because my bladder's, I've got frequency. I'm seeing my gastroenterologist because I've got fecal incontinence, and I'm losing the feelings in my legs. And no single healthcare professional has joined that connection between the interplay of radiotherapy causing all of those challenges. So it's a pleasure to be here this afternoon. I will make sure that you all have contact details if there are any questions that come up or information that you want following on from this. But yeah, hopefully can be part of the panel this afternoon for you.
Thank you very much, Lisa. I think it's just so important for us as lymphedema therapists to remember everything you said in terms of all the other effects of that radiotherapy. And obviously, we're specialists in our field for the lymphedema, but it's so common for people to then share with us the devastating effects of radiotherapy to the pelvic region. And obviously, we just want to help with the bit we can help with. We've had some questions come in on the chat, so I'm going to get started with that. So first of all, I'll put this question to you, Matthew. In your presentation, you mentioned that 1 in 1 patients who've had penis cancer develop lymphedema. That's obviously all of them. So yeah, just wondered if you could explain to us why that is.
Yeah, absolutely. Thanks, Lorraine. I think this is due to usually being quite radical surgeries and treatments that are carried out for that type of cancer. There's usually a lot of surgical input, significant radiological input, and I think the risks are just really high for damaging your lymphatics alongside that. Yeah, so mainly just to do with that. There was a second question as well, Lorraine.
Related to sort of should these patients therefore all be referred as a preemptive thing, and just wondered what you do in Wales if the patients get referred at the point of their treatment, or if you do wait for them to develop the lymphedema and then risk that being a later referral.
Yeah, so we would accept referrals as a risk reduction.
Yeah.
So they could get referred as a risk reduction, just because we know how high of a risk that this is, and the evidence is quite clear about that. But there aren't any sort of formal programs that we've set up directly. I think in the past we have. I think the same with lots of other services. We just struggle to maintain staff and resource for that.
Lorraine, can I just come in on the back of that as well? Because one of the pieces of research that we did a little while ago was looking at the risk of developing late effects of pelvic radiotherapy. And what we saw was a synergistic effect with multimodality treatment.
Okay.
So we have a patient who is presenting having had surgery and having had radiotherapy. The risk of them developing late effects might be 5% for one and 5% for the other, but it's likely to be 20% if they have both treatments. So I think, again, that it's really helpful if you're working with patients to have an understanding of what their treatment plan looks like, and therefore their potentially elevated risk of late effects.
I've just got one follow-up question to particularly the penis cancer lymphedema patients. So in your experience, either of you, where do they tend to develop their lymphedema? Is it midline, is it leg, or is it both?
It can very much depend on what kind of treatment they've had, what kind of surgery they've had, and the surgery can vary quite a lot as well.
Okay.
So if they've had a penectomy, then maybe not, but there may be more lymphedema around the mons pubis area or the scrotum, or again, it just depends on. It can vary so much in terms of surgery then, but usually you can see some lymphedema around the upper thigh area as well.
And I think what's really important with that is the communication from the surgeon around, actually, this is the surgery we're doing, these are the lymph nodes that we're going to be potentially impacting on, and therefore this is where your risk is most likely to be.
Yeah, definitely. Yeah, patient education at the point of the treatment, so they know what to look out for, know the early signs. So important. We then had a comment, it's not so much a question, but a comment that there was no mention of endometrial cancer. Any reason for that in the presentation?
So I pulled my cancer statistics from the Cancer Research UK website. So there wasn't anything sort of specific on there that I came across. So apologies if I've...
Well, I wonder if it is relating to the risk for that group and the treatment that they undergo. Yeah.
Yeah.
We've got a few requests for copies of the Lymprom.
So I have contacted a colleague just to double check. I'm just waiting for a response.
I think probably one for you actually, Matthew, because when I attended ILF last year, I asked for a copy, and I bet you've got a process in place, so I had to apply for it, and there was like a nominal charge of £1. And basically go through that process, then you get access. It's just so that is it Cardiff, University of Cardiff, then monitors the use of it, so you know who's using it and know the outcomes. So sorry to jump in on your question, but
thank you. That's what I thought it was, but I want to didn't want to assume that was still it. But
it's
I
really
think this
fantastic tool.
yeah. So it's a nominal fee of £1, so that you can contact our generic email address, which is Lymphoedema Network Wales @wales.nhs.uk. I'll put it in the chat.
And I just would like to mention also there's the LymQual, which Derby do, and we use that one actually in our service, but they're both excellent sort of tools. So there are other, quality of life tools available. And you also specifically mentioned the genital one, didn't you? Which is not a Lymprom, is it? It's a different tool.
Yeah, so the genital is more of a self-reporting tool.
Yeah.
So yeah, so it's for patients to complete and highlight. I think a lot of the difficulty around this subject is people don't like talking about it, and that can be healthcare professionals as well as patients, and sometimes having a form to fill out, some picture diagrams to draw on, will just increase that likelihood of something being reported.
And I think one of the barriers to healthcare professionals opening up conversation around intimacy and changes to the genital areas is around actually what do I do with this if I open up a conversation and challenges are presented. So I think absolutely just empowering healthcare professionals to feel comfortable and to look at what resources they can tap into if they open up those conversations would be really valuable.
Do we know if lymph node transfer is of use in this group of patients? Lymph node transplant, sorry.
Yeah, I think there is some benefit. I'm not a surgeon, so I struggle to answer fully. I think it is something that could potentially be really useful. I think just more work needs to be done around it. I think that's where we are at the moment. We just need to do more of it to work out those benefits.
Is lymphedema to the pelvic area a risk to anyone having surgery in that region, or is it really just cancer patients?
I would include everyone. Yeah, yeah. And any surgical intervention is a risk of lymphedema. If we think about where our superficial lymphatics are, any breaking of the skin can put us at risk of lymphedema.
I would agree with that. Yeah. And any tips or tricks of how to deal specifically with penile edema following cancer treatment?
Yeah, absolutely. So we're thinking about our sort of usual cocktail of self-management strategies then. So from a compression point of view, I'd be thinking about advising compression pants, or at very least double layering normal pants. When I say pants, I mean kind of briefs, something that's going to encapsulate our genitals. We can think about using foams within that compression layer. There are some there's some fantastic projects out there that can be considered, or speedos, or other swim shorts are available. But something that's going to really sort of lift and support. And in terms of that, I probably wouldn't limit ourselves to just thinking about what products are available, even though there are fantastic products. We've all got kind of different body shapes and types. So it's worth just having that conversation with our patients about, we're going to explore, see what you can find that might work better for you if we can't find something that's not quite working for them. Another string to that bow of compression then is self-bandaging. So teaching self-bandaging to patients. There are some cohesive self-bandages that we can use directly on skin. They are becoming hard to source, but they are still out there. Um, uh, but yeah, teaching our patients to bandage, and you usually bandage sort of distally working proximally. Um, so just important to remember that. Um, uh, Although there is a challenge, so toileting has to be considered in things, and again, after many of these surgeries, we're left with what could be considered sort of unusual shapes. So it's just trying to work out what's realistic, what's kind of possible. The other thing then, so massage, we
Mhm.
can teach our SLD, yes, but I would have a strong focus on soft tissue massage also. So just for the penis specifically, we can think about squeezing, sort of like a
Mhm.
pumping motion. So squeeze, hold for 10 seconds, release, squeeze, hold for 10, release. Um, the other thing as well then is if we still have our foreskin, is making sure that we can still retract that, and even just doing that a couple of times will will help keep tissues nice and soft. Um, in terms of scrotal edema, it's kind of holding, lifting,
Mhm.
and doing the same sort of process. So hold, lift for 10 seconds, release, hold, lift. You think about sitting on a towel and doing the same thing.
Mhm.
If reaching down is a bit of a difficult scenario for our patients. Um, you think about sitting on a rolled up towel.
Mhm.
So having a towel that's rolled up to sit on, just to give some extra additional support there. Um, um, there is probably much more to I could probably talk about, but right now I'm forgetting.
I
Um,
think the towel
you
tip's
can,
really helpful because it's sort of some people are very comfortable maybe touching and doing their own massage, but some might not be, and it just gives that option, doesn't it? Um, yeah,
and we know that people doing things daily, self-management is going to be much more beneficial to us coming in with an intensive block of treatment and then nothing.
yeah.
Um, so big emphasis on the self-management techniques would be is so important.
Thank you. You've given us lots of tips there. Um, just looking at you, Lisa, I won't ask you if you've got anything else. Well, our next question I wanted to ask was about acupuncture. We've got an acupuncturist in the audience, and she's saying that she's aware of the guidance for upper limb, but is there anything specific for lower limb with regard to the safety of carrying out acupuncture?
I'm not aware of anything specific. I can't see why there would be a difference for upper and lower limb in terms of guidance for acupuncture and lymphedema. Um,
I
but
agree.
I don't know of anything specific there. I'm not sure if Lisa might be aware of something from Maggie's.
No, so we actually offer acupuncture within Maggie's. So for mainly for hot flushes, so for people who've had breast cancer, so they will have upper limb or potentially you are in doubt, just a quick message, just to check that they're happy. But there's no evidence to suggest that we shouldn't be.
Fantastic. Well, we've got a really good question from a physiotherapist saying that she calls patients 6 weeks post-op following colorectal cancer surgery for physiotherapy follow-up regarding exercise. What should she be asking them to screen for lymphedema?
I think I think it's important to remember that patients may not be aware of language like lymphedema.
Mm.
So perhaps we should be using terms like swelling. Do you have any persistent swelling? Is it
Mhm.
is it resolving? Um, is it fluctuating? And just start with that and see what that opens up in terms of a conversation. You'd usually expect some post-op swelling. So
Mhm.
so 6 weeks. you might still see some post-op swelling, but you're hoping most of that has settled down. Lisa, do you have any suggestions that you might ask?
Well, I run sort of Aware Now course, so it's for 6 weeks post-treatment around all of the challenges. And one of the things when I talk about lymphedema is when patients ask, what do I need to look for? And particularly with lower limb, it's about actually, do your socks leave a mark when you take them off and they haven't previously? Are your boots being in tighter around, particularly if it's one limb rather than two limbs? Because generally, in most cases, it's one side that's being treated more than the other. And it's something similar with upper limb, are your rings becoming tighter? Is your watch tighter? So they're very measurable things that patients can observe. So it tends to be what we mention.
Absolutely. And I think it's important to remember as well if we've got any sort of doubts over that reporting, because I know from telephone triages with patients, do you have any pitting? Are you able to push and leave a mark? And that's sometimes reported as yes, but what they've actually meant is capillary refill. I've left a I've left a white mark, but it's filled back up. Yeah. And actually when they've been seen face to face, they do have swelling. So yeah.
Thank you both. We've got a question about antibiotics and should we be using them as a preemptive if someone's had pelvic cancer treatment and then they're maybe going to have a hip replacement or a knee replacement. So they're due to have some planned surgery. They've got a history of having pelvic cancer. Let's say they've had some radiotherapy and some surgery. Should we be giving them antibiotics for their surgery?
I think as a routine, perhaps not. But I think this is where everything's sort of looked at as an individual patient basis. So I think surgeons are fantastic at weighing up risks and benefits. And I think it's just opening that dialogue with the surgeon about those risks versus benefits. I don't think we want to be using antibiotics routinely for everyone as a preemptive.
Yeah. Just in case people aren't aware, the BLS and LSN have got the cellulitis guidance, which maybe one of the girls will put in the chat or it might be on our follow-up email. But we do have BLS guidance on, and in there is something about that specifically. I think it's around if people have had cellulitis before. So if it's a known person that's having recurrent cellulitis, then that the advice might change. But we've got an interesting question about cycling. So are we aware of any adverse effects for those who are keen cyclists?
I'm not aware of any adverse effects, no. Interestingly, sometimes we can recommend wearing cycle shorts for managing genital edema. I suppose, no, I'm not aware of any effects. No.
Yeah, I guess it's the logic of the question, isn't it? That actually cycling for a long period of time can be quite traumatic to the genital area. So if that area's got lymphedema or is at risk of lymphedema, I guess it's just self-monitoring, isn't it? And being aware of if the area goes hard, then to get it checked out, So yeah, I think it's a good question. It's something to be aware of, maybe. Sorry, I've got very interested in all the questions. So any experience in red light for wound healing or any other healing interventions? Any experience in I think that's the photobiomodulation, probably relates to that question.
Is it the low-level Thor laser therapy? So some experience with it. I've not used it for quite a long time. Lisa might be more aware of things with a radiology background, but she's shaking her head.
No, I don't have any.
My understanding is that it will stimulate the mitochondria in the cells to promote more oxygen, and that can sometimes relate into promoting more wound healing then. So yeah, I think it's important to remember that these additional tools exist. I don't think, and I probably use the emphasis on the word additional there. So I think it comes down to our fundamentals and getting those right. But it's always important to try and include other modalities as well, especially if we're struggling, we're not kind of making progress. What else can we think to add in?
And we've got a comment in the chat that long distance cyclists have been known to get lymphedema. This has been presented at our conferences in the past. So I'll just go back to that comment from Julia. Thank you. We've got quite a few comments, questions about early intervention, early recognition, the importance of that, patients being sort of dismissed maybe in the early stages. Just any tips, tricks, comments, ways of managing that in terms of what to look out for, generally with early intervention.
Yeah, so just to be clear on that then, so what are we asking? Repeat it again for me, sorry, Lorraine.
No, that's fine. We've got several questions on, let's go back to a clearer one. What are the early signs and symptoms of pelvic lymphedema that we should make patients aware of?
Yeah, it's really tricky to answer. It's that persistent swelling. Until you have the swelling, I'm not too sure about any other signs or symptoms. You could maybe get some heaviness or some achiness, some pain, but that could be a number of different things before thinking about lymphedema. So I think it's a tricky one to answer about early signs of lymphedema until it's present.
And I think probably my sort of feed into that is very much I get a number of patients that I'm working with post-treatment who, when we talk about lymphedema, say, actually, what is lymphedema? So it's almost how do we educate patients at a point of consent so that they are aware of what to look for, because actually if it's a very minor change and they're not aware that lymphedema may be a problem, they potentially aren't going to report it. So it's about really good patient education, I think, at a point that enables them to be self-empowering and aware of any change that happens.
That's really interesting.
Thank you very much. We did have another question about LVA. It might be a similar answer to the lymph node transfer answer, but have you got any experience in whether LVA is useful in pelvic lymphedema?
Yeah, and actually, what we're noticing in Wales is, and the surgeons would be best placed to answer this question. But my understanding is what we've noticed in Wales is we tend to be having better results proximally with the LBA surgeries. So not specific to our cancer-related lymphodemas, but certainly when there's been more anastomosis on the proximal area, that tends to be a bit more beneficial. Yeah.
Thank you very much. I think we've exhausted most of the questions in the chat. I'm just going to have a little look down here. Lisa, I just wanted to also just get you to just remind us of all those other things that these patients are dealing with. I think that would be really helpful, just to have a sort of little think about all the other things that they might be dealing with following pelvic radiotherapy.
So I think really we can state the obvious. If we're offering radiation to the pelvis, we'll be including the bladder and the bowel, so automatically bladder and bowel changes can be frequent. And that may be fecal incontinence, urinary incontinence, frequent UTIs. We've then got the risk to the vaginal tissues, so vaginal stenosis, which obviously would have an impact on intimacy and penetration. We'd be irradiating the ovaries, so patients will be put into a treatment-induced menopause. So that's a more systemic change, so risk to bones, heart health, brain health if they're under the age of 45. And then because we're including the spinal cord at the back, we may well cause long-term nerve damage. And it's interesting, I'm actually seeing someone this afternoon who was treated 30 years ago, someone I treated, she's now got a secondary bladder cancer. She was treated for cervical cancer, but now got secondary bladder cancer, colorectal cancer. She's completely unable to walk due to the nerve damage. So the side effects from her radiotherapy, actually, she will die from her side effects. So we can't underestimate the impact these effects can have. And I think probably the other really important thing to hold on to is the fact that these long-term effects of radiation can occur anywhere from 6 months to 30 years post-treatment, which is the challenge when people are presented to their healthcare professionals a while down, or sort of after they finish their treatment, and it potentially is related to their previous radiation treatment.
Thank you, that's really insightful. I'm just going to add just one comment. There's a question coming late asking, how long after surgery would you recommend exercise or MLD as a preventative? Well, we don't recommend MLD as a preventative. That would be a treatment for lymphedema as opposed to a preventative. And in terms of exercise, we would want people following their exercise plan immediately following their surgery. But I just wondered if, Matthew, you had anything else you'd like to add to that question?
No, that's exactly it. It'll all depend on what surgery's happened, and usually there'll be an exercise plan post-op with the surgeons working with the physiotherapists. But and yeah, generally though, from a selfish lymphedema perspective, the more we move in, the better.
Absolutely. Well, that brings us to the end of today's webinar. Thank you so much, Matthew and Lisa, for helping the BLS promote the awareness of pelvic lymphedema. It's so important. So just wanted to make everyone aware of tomorrow's webinar. So tomorrow our webinar is about compression therapy in lymphedema, success or failure. We've got the wonderful Natalie Phillips doing that with the BLS tomorrow. Also wanted to make everyone aware of our up and coming study day. So we've got a study day for non-lymphedema specialists. So if any non-lymphedema specialists joining us today, you might be interested in our introduction to lymphedema study day, which is being held on the 6th of October at Chester Racecourse. This study day is designed to ensure you're equipped with the knowledge and confidence to spot lymphedema early, provide supportive care and collaborate effectively with specialists. Someone will pop a link in the chat to this, so you can be the first to register when the registration goes live in April. Thank you so much for everyone for joining today. That's the end of today's session.